do you want to just like?
All right, if I'm too loud, let me know. It's an actual danger. So, but before I get into this, I want to stop for a moment. So, there's a debate about what may happen, but the bottom line is tonight there was a procedural vote to go ahead with debate on one of two things, both of which would likely gut Medicaid in the form that we know it, including Medicare. And I want to recognize what Dr. Chen and her team do in the face of wild opposition from her own country's leadership. So thank you for doing that. But it'd be nice if people supported rather than tried to stop. I'm done with the political grandstanding, maybe, I'm not sure. All right, so I'm here to talk to you about some experiments that I have seen work really well in marrying of technology and healthcare. I have been all around the healthcare system. I have worked for an academic medical center, Partners Healthcare in Boston, which owns and operates Brigham and Women's and Massachusetts General Hospital. Perhaps you've heard of them, and also a bunch of other hospitals that they bought up in Eastern Massachusetts to become a powerful monopoly. Very successful. I have also worked at Aetna, also known to you as the third, might have been second largest private health insurance company in the United States. I have worked at the people who mysteriously pay for healthcare, the big self-insured employers, the Pacific Group on Health. And I currently have ended up in the fourth place around the healthcare table on the industry side, working for a medical device and pharmaceutical company called BTG, which is British, owned and operated, publicly traded, and US headquarters are in Philly. Notice that I said there are 4 seats around the healthcare table, and notice that I said employer, payer, purchaser, and provider. I left out patients. One of the big issues is that the patients don't sit at the table. Kind of sucks for them, because everybody makes a lot of money off of them existing. So here's a little sort of picture of what the mess is. Here are some things I've done in my life. I built the first web-enabled quality scorecard for a big academic center that was Partners. I designed a plan for electronic exchange of health data of 40 million Californians. Anybody know what the state health information exchange is in California? Anybody need it?
Covered California.
That's the insurance. That's the insurance one, you're right, but that's the insurance. The information exchange? Close? Nobody can because it doesn't exist. It didn't exist. Because we didn't do a good enough job designing it. We tried really, really hard, but it turns out seamless liquid data between all the stakeholders in the healthcare system is actually difficult. Who knew? So we just went back to faxing, which is what we do. Great job. Good thing on my resume. It's awesome. I have secret shopped health insurance consumer tools. They all suck, all of them. And I have mentored many digital health startups, so that's me. So what I hear a lot from startup people, very well meaning, super brilliant, really good, is I'm going to disrupt healthcare. Here's the bad news, no you're not. You know why you're not? Because it is $3.2 trillion this year. That is bigger, almost $0.2 trillion of the GDP of Germany. All of Germany. All of the things that Germany does and makes. Nobody wakes up in the morning, not even me, and I have a titanic short person ego. Nobody wakes up and says, I'm going to change the entire GDP of Germany today. Okay, so what can we do? I like that you like that joke, that's nice. You can make significant lasting change, but you have to realize a couple things, and Dr. Chen actually talked about some of these. The system is fragmented and rife with cross incentives. If there was one simple answer, we probably would have done it by now. We're not dumb, right? There are plenty of problems to fix if you can create real value for stakeholders. There are things that make doctors and patients and hospitals and payers happy. Your job as innovators is to find them. And we need your ideas because at this current rate of growth, millennials, which I am too old to be, will spend half their income on healthcare over their lifetimes. That's called being an indentured servant to healthcare, when half of what you will own of your whole life will just go to not die. All right, so who are these cross-incentive fragmented stakeholders that I just talked about? Here are all the people that you have. So you have the people spending on healthcare. Those are Americans themselves. We spend a tremendous amount on our own care, even when we do have insurance. They are employers, a lot more on this in a moment. And then there is CMS through Medicare and Medicaid, and then the states through Medicaid. We have suppliers, vendors, and industry. These are the people selling to the other people around the circle. Pharma, med device, imaging, biotech, obviously, and then a big health IT sector too, right? Which sells IT systems, electronic health records, clinical decision-making tools, patient tracking, claims adjudication, all those systems that we use, fax machines, etc. In the upper right-hand corner, we have the payers. We have 8 national private payers, 8 accredited Medicare providers, 40 key commercial payers, and over 850 regional payers. People like Blue Cross Blue Shield of Southern Illinois, right? Then we have the regulators. We have a bunch of people involved in this. One of my favorite things here, and Dr. Jen did a lot to rehabilitate physicians in my eyes, but the people who set the rules for how all of this is paid are actually doctors. The American Medical Association writes literally the code book, so that's kind of cool. I too would like to write the book on how I'm paid. On purchasers, those are generally employers, but they can be people who buy any form of benefits on behalf of anybody else. Unions, for example. That can go from one self-employed person buying insurance for themselves to 1.1 million people, which is Walmart. And then you have various coalitions, et cetera. And the issue here is that human resources folks, who are very great people, some of them are my friends, they're making decisions about healthcare on which they are not experts. They don't say they're experts. They don't want to be experts. They leave it up to everybody else, and that's how you get some of this mess. Whoop. All right. Employers, okay? Employers. It's so weird nobody talks about them because the amount of money that they spend on healthcare is insane. So weirdly, after World War II, we had wage freezes. So the ways that employers could compete for great talent is by offering things like health benefits and insurance. Then this got enshrined forever, ever, because corporate tax policy means that employers pay less in taxes on what they give you in benefits than what they do in salary. So they want to pay you a lot in benefits and as little in salary as they can. And then the ACA took another step forward in making this permanent by saying employers over 50 employees must offer health insurance to employees working 30 hours or more. This was incredibly decent in terms of getting people to be insured, but it just sort of bulwarked this system more. Of everybody who is on the employer side, self-insured or more than half, fully insured is less than half. What does that mean? If I'm a self-insured employer, I literally pay out of my own pocket every time an employee or dependent goes to the doctor or the hospital. There's no insurance here. This is not insurance, okay? If I'm Costco and my baker in one of my stores goes to the doctor, Costco opens the bank account and Aetna takes money out of that bank account and gives it to the provider that treated that baker. There's no insurance, right? But it makes sense to do this if you're Costco or if you're big because by nature, your population is healthy compared to the average because they have full-time jobs and they're working. So why would you pay a premium to a health plan? Because they say your risk is X when you know your people are pretty good. You'll take the risk yourself, thus self-insured or risk-bearing employers. All right. Okay, why is healthcare broken? That's what I think. The big thing to realize is that everybody is at fault. Everybody is profiting from exactly the same bad situation. Everybody's feeding at the trough, me included. Hospitals set their own prices for each plan. They operate like unregulated utilities, right? The beating the can, every time you make noise, you get paid. Physicians, same thing. In a fee-for-service world, more procedures, more income. They're basically individual businesses. They don't really have bosses. Corporate practice medicine and increasing sort of buyouts are changing some of that. But the bottom still remains that physicians most expect to be paid the most out of any occupation in the US. In fact, 9 of the top 10 highest earners in the United States, as data analyzed by Forbes, are physicians. They're specialists, they're not primary care. Primary care physicians are woefully underpaid, they're specialists. Does anybody know what number 10 is? 1, 2, 3, 4, 5, 6, 7, 8, 9 are physicians. Does anybody know 10? Highest earner in the US? Insurance company CEO. But doctors, they can more. Price's specialty is in that top 8. Insurance operate as a rational private enterprise to maximize profit, act as third-party administrators who benefit from higher prices. A lot of times I hear insurance companies are evil. How can they do that? If they just went away, everything would be great. Here's the problem. If you are a publicly traded large corporation insurance company, your fiduciary responsibility to your shareholders, the way you create profit, is by denying claims and increasing premiums. If you want to point a finger at the people who thought that was a good idea, point it at ourselves, because we're the society who thinks that's an awesome way to pay for healthcare. Brokers, paid on a percentage basis, so profit from higher cost of care. So broker is somebody who helps you find health insurance. Pharma, life sciences, biotech, pointing at me, unregulated, protect their R&D no matter what, lack of price transparency, right? No idea what it costs to make or research or commercialize a drug or market it. We're just trying to protect our patents. Ancillary services. The greater the turmoil, the greater the need. We need step-down facilities, we need nursing, and we need emergency transport, and we need all kinds of things, because the rest of this is a mess. Consumers have little to no financial interest in their purchase decisions, but expect maximum choice, quality, and instant service for free. Yikes, right? Everyone benefits from the status quo. No one is motivated to change it, except for me, apparently. Costs are individual and unshared. This is why I'm so angry all the time. So here's the good news. What's changing in US healthcare? Everything. Because of this move to value-based payment. Everything is changing. And this is a little bit of a picture of what it looks like. So this is, Dr. Chen covered a lot of these, but basically, in delivery, the trend is from brick and mortar where I can physically see you to wherever you are. It's a good thing. Reimbursement from volume to value, we know about that now. Policy regulation is moving from what is the clinical evidence as decided by a doctor and what is the code as decided by a doctor to, I don't know, ask the patient if they can walk again. That seems good. Decision makers, the provider and the payer, now we're increasingly moving to the consumer. Some ways of doing that are better than others. The structure is business to business. We're starting to incorporate the consumer at the end of that change. Our chain payment is moving from risk, this is how an insurance company measures things, what's the actuarial risk of you dying within 1 year, to retail. Let's pay you for how you're actually able to function afterward and how well you do, and compared to all the available clinical evidence. And then the value creation is moving off of process to actually outcomes, and that's the area of greatest hope. So basically, if your thing helps us move from here to here, you're on the right track. All right, so what are physicians and hospitals looking for? I'm not going to go through everything on the slide, but essentially there are a lot of Medicare programs that favor this. There are a lot of private insurance contracts that they write with doctors and hospitals that favor this move. It's really focusing, 1 and 2 are good things to do, but it's really focused right here on improved outcomes. How do we support the physician in making a better choice for this patient? How do we know more about this patient so that the suggestions we're making are more tailored? And then how do we help the patient take better care of themselves after the intervention? All right, here's the thing. I love patient-reported outcomes measures. I love this, I love this, I love this. We started out with, okay, here's a process you should follow. Then we decided quality was a big deal, right? And quality is a good thing. Did you follow all the clinical guidelines for treating this patient? Did you wash your hands? Did you follow the checklist for administering anesthesia? These things are awesome. But as I once had a cardiac surgeon yell in my face, I did a perfect surgery. It was clinically perfect. And I had to look up at him and say, "Doctor, the patient died." But that doesn't matter. You can have perfect quality and still a terrible outcome. Why? I don't know. Let's ask the patient. So here's how this sort of evolves. A patient-reported outcome is something the patient experiences. Depression. Here's a patient-reported outcomes measure. It's an instrument for measuring depression. You can't fix something you can't measure. So we have one. It's called the PHQ-9, standardized tool to assess depression in a population. Then you have a patient-reported outcome-based performance measure. Now you know how to measure, you got to get people to change, so you have to hold them to the benchmark. So then you say a percentage of patients with diagnosis of major depression or dyspnea and initial PHQ-9 score of over this benchmark but under that. Okay, based on a national quality foundation measure. Great. Then that makes its way into the payment system, right? The 2016 CMS endorsed quality measure is the depression response at 12 months. Then this is supposed to back its way all the way up in the delivery system and all the things necessary to meet this measure change. Here's the problem. I've been practicing one way since the history of medicine. Help me do this. And that's a solution that a physician might be looking for. All right, what are health plans and employers facing? So they're looking at ways of controlling costs in a population. That's how you get to good value-based contracts. But if you're a health plan, you only care about the things that cost the most money. You can't chase everything, right? And we know that 5% of people drive 50% of the cost. So what are those conditions that a health plan or an employer cares about? Here they are. Cancer, another cancer, renal disease, although sometimes this is paid for by Medicare, so it comes on and off. Congenital anomalies, conditions present at birth, and then another birth one. Maternity is a nightmare for health plans. One person just turned into 2. It's awful, right? So much money I'm spending, and I can't control it at all, right? But when things go wrong, they're also incredibly expensive. So what can we do to figure out what the right treatment for each cancer in that individual patient is, according to how they would want to live the rest of their life, which is often not maximum intensity care until death. How funny, the patient doesn't want to spend that much money on themselves either. How do we accommodate that? How do we support healthy moms, healthy births, make sure that all these things that might be preventable are stopped. All right, here's some more opportunities. So consumerism, health plans are terrible at talking to human beings. How do we help them do that? Cost shifting, how do you make somebody practice the behaviors that you want them to practice? How do you get them to want to be healthy? Now the tough thing here is that you run into the problem, and health plans are not handling this very well, that cake is delicious today and diabetes hurts tomorrow. I, too, am part of that thinking. So how do I help people understand what to do? I think we can take a lot from the idea of 401ks and saving for the future, and helping people default into programs that ask them to save. And I'm not saying pay for their own healthcare here, I'm saying do behaviors that make them healthy. And then moving from 150 years of claims adjusting. That's what Aetna has done for 160 years, is adjudicate claims. And all of a sudden, they have to help doctors and hospitals do the right thing. They don't know any better than we do, so we have to help them out. Woo? All right, coming to the end here, I promise. More opportunities, employer cost control experiments. So a couple things I worked on when I was at Aetna. Back to the moms and babies, we had a very cool program that really helped moms do the right things during pregnancy. And it was totally free. The problem is we're a health plan, we don't know you're pregnant until you basically give birth. Seems a little late. So we partnered up with a great set of apps to support moms called Wildflower Health. We just put in one screen that says, hey, do you happen to have Aetna? Because if so, call this number, give me your member ID, you'll get this free program. And all of a sudden we were getting people in the first couple weeks of pregnancy. Good deal. Where is your pain? Turns out that a lot of people have pain that they get expensive surgeries for. It could actually be better managed by physical therapy. But most employers and plans limit physical therapy benefits to 20 sessions. That's really dumb because it really helps. So how do we help people do that at home so they don't have to miss work or miss childcare or leave or do whatever it is to actually get them that physical therapy? And then the last one is very simplistic, but we were trying to help people understand why weight loss and maintaining a healthy weight and maintaining a healthy waist circumference was important. Turns out if you tell them it's in their genes, they let go, like they're a predisposition to being fat, like I do. Turns out that they let go of all the guilt about it not having good self-control or whatever, and they can say things like, I'm gluten intolerant, or I have a predisposition to fatness, so I don't want the bread basket. I do this myself. It's much easier than saying I'm on a diet. It's very shaming. It's much easier than saying I just can't control myself. If you're taking care of your health because it's your genes and you have an illness, way easier to do the things you need to do than it is when you've been beaten over the head with like terrible messaging your whole life. So give them a genetic test. Don't even read the results. Just say, hey, move more, eat less. It'll work for you. I'm very pragmatic. All right, what do consumers want? To not be sick. They don't want to consume healthcare. They don't want to play games with healthcare fun. They don't want to talk to their insurer. They don't want to look at their HSA balance. They just want to not be sick. That's all they want. So be very careful with your direct-to-consumer app. What is the most successful healthcare app to date? Anybody know? Most successful healthcare app, most downloaded, most money, all these beautiful stats you see here.
Pokemon Go.
Pokemon Go. That's right. It's not a healthcare app at all. Try to make a healthcare app, it sucks, everybody hates it. Do something that actually drives the outcomes you want, increase social interaction, moving more, happier mood, and then you get the results you want. All right, last couple things.
That's somewhat limiting to certain age groups though?
No.
Actually, no.
Don't touch me.
No.
Program,
I think there was a greater diversity of players in Pokemon Go than you would expect, but you do speak to a good point, which is that we do make a lot of one-size-fits-all solutions, and we need to think more carefully about offering.
Well, that may be true on the game side, but
Yeah.
on the healthcare and digital health side, I think there's a definite age bias.
Oh, of what gets made?
What gets used?
Yeah. No, I think that's absolutely true. I think I see a lot of people making a marathon running app, and I'm like, really? Because I need something for an 85-year-old with diabetic who already lost his feet. That's what I'm trying to help here. Okay, so I think we've absorbed these lessons. All right, here's the things that consumers actually want. When you ask them, I want a cost estimator. How much is it going to cost me? Just tell me. I want simple access to my health records. You do not own your health records. And in only a handful of states can you actually request them for free. Mobile post-care instructions and follow-up notifications. Please don't tell me when I'm naked and terrified and just been operated on what I'm supposed to do. I'm not gonna remember. And then you give me a mimeograph sheet where half the text is falling off the page. Awesome. Could I please have it in a way that I could actually follow and share with my family? Online appointment scheduling, everybody wants that. Central payment portal to payers and providers. Give me a way to manage this. To me, health is money. Help me understand how to do that. You have some examples from how we want that experience to be in the upper right-hand corner. On behavior change, the latest evidence is that incentives are okay. Carrots and sticks, meh. Peer pressure always works. You know, you want to do what your friends are doing. Artificial intelligence, automate your mother's nagging. This really works. It just has to be relevant, right? So AI, big hopes for AI that it can do that. Here's what consumers tell us about that they care about less. Telehealth is good for convenience, but it doesn't replace that ongoing relationship with the physician who knows everything about you. Wearables where the data goes nowhere, oh my God, please. Self-diagnosis tools and self-management programs. Please stop shifting the burden from you to me. Instead, give me things to enable what I want to do. It's a big difference then. Oop. And then last thing, I hear a lot about ROI, ROI, ROI. Go back all the way to my first couple slides, creating value in healthcare. You gotta find something that makes everybody around the table happy or else they're gonna come and kill you in the night. So ROI in normal life, in normal healthcare, is immediate improvement in revenues for healthcare stakeholders. Everybody likes that, right? Or demonstrable, repeatable, significant short and long-term cost savings. You want to do one of those. That's what somebody's going to pay for. What is not ROI? Engagement. Who got healthier? I don't care who used the thing. What actually happened? Value-based care. If you can enable my transition to it, that's great. But tell me how it does one of these two things, because that's still how I stay in business. Better outcomes. Who does that have an ROI for? Maybe you help a ton of patients, and that is so good, and you're totally going to heaven. But who does that create an ROI for? So I think if you can put these pieces together in a business case around what you're innovating, you can get a lot of good done while still getting to scale. So last, that's not me, obviously, that is Patrick Stewart. But I put this up here because I don't know like what this thing is. It's like a folding tablet computer nonsense. But the point is that when this aired in 1994, everybody was like, that's crazy. You're not going to carry a foldable tablet computer. It's not. We have a computer way more powerful than that we carry around in our hands all the time. So you always wildly underestimate the change that can happen in 10 years and you overestimate the change that can happen in 2, so keep at it.